Thank you all for joining. And Henrietta, thanks so much for giving us your time. It's great to catch up with you. If we just move on to the next slide, Holly. And the next one, please. So we are just about to start recording, so that we can put it on our website for people who were unable to attend today. Please use the chat box to say hello and let other people know that you're here. But if you could use the Q&A so that I can keep an eye on the questions that are coming in, that would be brilliant. Closed captions function has been enabled, and I would just be really grateful if you didn't take photographs of our screenshots of the speakers. So we're going to get going because this isn't going to be a slideshow. It's going to be a conversation. Henrietta, welcome. Thank you so much for coming.
Well, thank you so much for inviting me and having me back.
Pleasure. With pleasure. As we said, we see quite a lot of each other. So a whole year in post. Well, a little bit over a year now.
Yeah, so it's about a year and a couple of weeks, and it's been a really busy.
Okay. That's Henrietta frozen.
Right, Rachel.
Oh, you're back. Sorry, I couldn't hear you there for a second.
Oh, sorry. Is that better? Can you hear me now?
Yeah.
Great. So yeah, I was just going to say it's been amazing having that opportunity to speak to patients and families, and I can see, some of the people who we've been working with have joined this afternoon. So thank you so much. And starting to see some things happen, which I'm really pleased about, but there's still a huge amount more that we need to do so that patients and families get listened to at every stage, in every part of the design and delivery of healthcare, particularly in relation to the medicines and medical devices.
Brilliant, thank you. So I think a lot of what we'll talk about today is listening to patients and their families, and around that shared decision making and that consent. So in the first instance, what do you think what has been the best thing of the last year for you in terms of, I know you've been engaging with a load of people.
Yeah, so talking to families and patients who've been affected by the areas that were highlighted in the Cumberland Review, and then being able to move some of those aspects on. So if I start with sodium valproate, the day after I started in post, a patient sent me a photograph of a box of sodium valproate that had been dispensed to her in plain packaging with no warning labels and no information leaflet. And, as a consequence, I saw a whole series of events have unfolded, which are going in the right direction. First of all, the General Pharmaceutical Council wrote out to 91,000 community pharmacists, to remind them that they should not be issuing sodium valproate to people at risk of pregnancy without the warning labels. Second of all, working with the minister and officials at the Department of Health and Social Care, the consultation on original packaging for sodium valproate has been responded to, and I'm really pleased that a statutory instrument was laid last week. And so it means that pharmacists now have got the ability to be flexible when it comes to a prescription. So if the GP, and I'm a GP myself, does a prescription of 28 tablets and the box size is 30, they can actually dispense it in the original box. Now, this might seem small, but it's huge because it's about looking at what really matters to patients, looking at the risks of taking a medicine, which could cause harm to a baby and their whole life. And then saying, well, what's the practical, sensible stuff that we need to put into place? And there have been other aspects around, for example, redress, that the ministers asked me to look at redress options for sodium valproate and pelvic mesh. And I see that this is a real kind of move forward, from the recommendations from the Cumberland Review. And in terms of pelvic mesh, one of the things that the patient groups told us was a real gap was that GPs didn't all know about pelvic mesh complications, and so patients weren't getting referred on for their care that they needed. So we worked with patient groups and with gynecologists and Royal Colleges and NHS England and, GPs, so that we could design something that would be really helpful for patients and for GPs. And there's a letter on our website that patients can download, they can take a copy to their GP, and that's been not only welcomed by patients, but also we've heard that GPs have found that really useful, and it's helped patients move forward and get referred on or have the right investigations and treatment in the future. So it's things like that which are really tangible, which have come to us from patients that we've then been able to act on through the health system, up into government, into the regulators, into the parts of the system that are responsible for acting, and then seeing some really tangible impacts happening. And all the while setting up a team and getting an office and getting a website and all of those other things which are really important, but sometimes a bit hidden from public view in terms of starting a new organization.
And it's a huge challenge starting a new organization. So I completely get the setting up of your website. And I've met some of your team because I sit in your advisory panel, which, you can see the passion that you've given them in terms of the leadership. And I think for me, it's really obvious, Henrietta, how much you want to listen to patients. And that's why we love having you back to have this conversation, because it's all about listening to patients. But I just want to go back to a couple of things you said there. When you talk about medicines information, I know this year, as we've been involved and in looking at personalising that medicines information a bit more to the patient. What's your views on that? Because I think I've heard people say to me, especially if you've got more than one condition, they say I could wallpaper a room with the medicines information that comes out written small. And what other way could we be giving patients more power in terms of the medicines information that they get?
So last year I went to HSJ Patient Safety Congress, and I actually got a box of my own medicine. I took out the information leaflet that you've mentioned, unfolded it, and it's huge. It's cumbersome. I mean, I don't find it easy to read because of the typeface and the colors. It's not really designed to give people the information they need about their medicine. Sometimes it feels that it's more for the manufacturers or for the regulators. So I'm really excited now to be a part of a task force with some of the pharmaceutical companies, the trade bodies, and an academic health and science network to reimagine that medicines information, to be able to turn it into a digital format, and then to think as the next step about multimedia, so that it might be animations or in different languages or videos. And also, it's really excitingly having conversations with the team who are involved in the NHS app. So to see what could then be included into the NHS app, so that when you get your prescription or you're requesting your repeat, you can actually say, is there anything new I need to know about my medicine? Does it interact with anything else? Or what information have I got that I want to feed into that? Or even to do a yellow card report. So I think that this is about sort of modernizing and reimagining that information to say, look, yes, the statute says it has to be on paper, but the world's moved on. And what do people need? What languages does it need to be in? What's important? What matters to you? What matters to me? So that we get that information, we're able to really be true partners in our care.
That's important. And we were with Bola this morning, and we were talking about inequalities, and we were talking, the patient association is all about shared decision making, patient partnership in design and delivery of any service and any product. And I'm going to ask you more about that, because I know that you believe in that as well. But that what matters to you question not only means that the outcome is better for patients, but it means that it's a safer service, doesn't it?
Well, I've been really interested in this in terms of consent, because, as a doctor, I've been, talking to people for, well, nearly 30 years actually. And what is really obvious to me and really clear is that what matters is really personal. And so the outcomes of a particular treatment, or the way, for example, that somebody might want to use treatment, is going to be really different depending on individuals' ideas, concerns, and expectations. And so if we don't ask that what matters to you question, we're going to miss something huge. And we saw examples of that when it came to pelvic mesh and sodium valproate, and with a host of other issues as well. And I think what really is important here is that we need to know the medicine if we're doing prescriptions or using medical devices, but we also need to get the patient's perspective and the family's perspective, because otherwise it's a really big gap, and we are going to end up with situations where people have treatment that isn't right for them, they're not able to consent to it, and then we end up exactly where we are, for example, with pelvic mesh and with sodium valproate and with Primodos. And it just feels a real opportunity to understand the problems that have happened before, and then to learn and implement those lessons. So, for example, I sit on the program board for the MedTech strategy, which is part of the Department of Health and the Office of Life Sciences. And although I'm really keen that we're not acting as a barrier or a brake on innovation, we've also got to think about what would it take to make sure that we don't end up with those same issues from a whole host of other medical devices that have led to harm in the past.
And you mentioned consent, because there's a lot of work happening with consent. Where do you think we are as a healthcare system around consent?
So, in my view, consent should be the end point of a whole series of conversations, including the shared decision making, including personalized care. And from the very moment that somebody's thinking about what might be wrong with them and looking at the options, all the way through to potentially being referred into secondary care or community service, and then the point where a decision is going to be made about what's the ultimate treatment. And I look at this in terms of what are the benefits of treatment, what are the risks, what are the alternative options, have they been commissioned, because that's really important if alternatives haven't been commissioned, and what if we did nothing, what would happen if no treatment was done. And by doing that really straightforward, it's called BRAN, then we're not missing something when it comes to the information that people should be getting to be able to make a decision about their care. But one of the things I've discovered is that for different healthcare professionals, so doctors, nurses, opticians, and pharmacists, for example, all people who might be doing something or treating or maybe prescribing medicines, that their professional regulators got quite different approaches to consent. So working with the professional regulators, and Rachel, you're a fantastic part of that group, we're really exploring what does that mean for the future, and looking at some of the resources that already exist and why things aren't applied consistently and people have really different experiences.
I think, yeah, from a consent point of view, I think sometimes consent gets confused with shared decision making, and I think you're completely right. It's the end point
Mm.
of something rather than the beginning of the conversation. The beginning of the conversation is the what matters to you, and how we all get that together. And then I just want to go back to the leisure and the for around the pelvic mesh, which was the second point that you brought up, and the GP leisure that patients can download and give to GPs. I suppose, in a way, is that giving more patient power to the patient, so they have this to be able to bring to a healthcare professional? Is that where the letter comes from?
Yeah, I would see it very much as partnership working, because very often, most of the time, in fact, people who've got a condition or a long-term condition have got information that potentially the healthcare professional doesn't have. And so it's really important that people feel that when they do bring information to their GP, nurse, or other professional, that their views and their experience is valued and it's listened to. And sometimes it's helpful to have what we might describe in general practices as the kind of the ticket. It's like, I think I've got this wrong with me. And we've seen this so many times over the years, whether it's people saying, my mum said I have to come, or I've read this on the internet, or I saw this in an article. And it's really then drawing from that, what is it that somebody needs, and what are the alternative options that can be done. And as I said, in terms of pelvic mesh, I understand that there was some information a few years ago, maybe 5 years ago, that was sent out to general practice. But I know from my own experience and that of a lot of my colleagues in London that we never saw that information. It didn't actually reach the intended target, which is a real shame, because then what happens is people come to their GP and say, I've got this pelvic mesh and I've had these urinary tract infections, or I've got pain and I don't know why. And then, you know, if the person sitting in front of them isn't aware of what might be the problem, it can then create a lot of delay. But it can also mean that somebody doesn't get the listening that they need. That's why we thought it was really important to just put out all the information in one place in a way which was really straightforward, to really just act as a catalyst to a conversation between patients and their GPs, so that the GP could know not only about the side effects or the potential conditions, but also how to refer. Because, you know, maybe spend more time looking on NHS England website than others, but it wasn't immediately obvious to me that a GP could refer to any of the specialist mesh centres. And naturally, if somebody had had pelvic mesh, you know, put in locally, they wouldn't necessarily want to go back to that same unit for onward care. So by listening to patients and asking those questions, it became clear that GPs can actually refer patients to any of the specialist mesh centres, and we put that in the letter. So it's just really trying to improve the experience for patients, make it easier for their doctors to get the right information and do the right next steps as well, and just delay the, you know, reduce the risk of delay and then the compounded harm that I think people experience when they want to get help and that the people who are there to look after them don't have all the right information.
That's really helpful. This morning when we were talking with Bola, we were talking about, you know, left behind neighborhoods.
Mm.
We were talking about those communities that were not that were not, you know, I'm going to say the language, but it's a language makes me really annoyed. You know, that we talk about this hard to reach community. It's because we're
Mm.
not reaching, we're not out there working, trying to get into communities and understand communities. There is a question: how do you make sure your work can get to those voices so that you are engaging with a wide variety of people?
Yeah, I think that's a really good question. And so first of all, I think the core 20+5 approach, and anyone who didn't join the session earlier, I will guess that you've talked about that a little. It really helps to understand people who are less likely to be given the opportunity to give their views, quite apart from maybe feel empowered to raise issues. And we know that there are a lot of things that get in the way in terms of language, but also in terms of sort of opportunity. And for people who are, you know, working full time or more than full time, the chance of sitting in a you know, patient forum or a GP patient participation group is going to be less. So we have to be mindful of that and make sure that those views are included. So as part of my advisory group, as well as having Patient Association, Health Watch and National Voices, which does reach out into a wide range of different patient groups, we also have the Chief Exec of the NHS Race and Health Observatory, Habib Naqvi. And I just wanted to reflect a little bit on the health inequalities to do with medical devices.
Yeah,
And it may be familiar to some of the people on this call about pulse oximeters and the fact that during the COVID pandemic, it was found that they didn't give accurate readings for people who had darker skin tones. And I think that's really important, because when it comes to designing devices, there is a risk that if the information in clinical trials doesn't include some protected characteristics like race or about age or ethnicity, you don't necessarily know which groups are going to be worse off when they're using that device. And the Race and Health Observatory recently published a report about problems in newborn babies, not only in terms of recognizing problems like cyanosis, which doesn't get so well detected using the pulse oximeters, but also jaundice, which is less easily detected in darker skin tones, and the jaundice monitors don't work so well. So I think this is a real kind of movement that I've seen over the last few years in having these conversations, and not just having them with patient groups, but with clinicians. Even the word jaundice comes from the French meaning yellow, which isn't so easily detected in easy. It's more easily detected in paler skins, but it's also with manufacturers and saying, what are you doing to look at all of the people who might be using these, and who from your research are going to get worse outcomes than others, and how do we then do procurement so that we're getting the right devices, so that there's training and understanding for clinicians, but also for patients as well, and families, so that everybody has a part to play in this. And if I just think about an exemplar where this has worked extremely well, is in cochlear implants. So with cochlear implants, it was a 3 different groups were involved and continue to be, and that is the manufacturers, the patients and families, and also the clinicians. And when you get that combination of people working really well together, then you see that iteration and continuous improvement. And I think if we miss any of those groups, if we miss out the manufacturers, if we miss out the patients and families, and if we miss out the clinicians, we're not going to get the insights to be able to make those improvements for everyone who's affected by the use of medicines and medical devices, and also all other treatments as well.
Absolutely. And I regularly talk about, that there there are three people in this. There are the patient, there's the healthcare professional, and there's industry.
Mm.
And it still surprises me, um, with a couple of industry, thankfully not very many, who kind of tell me, well, I know somebody down the street who it worked for. And you're like, that's not patient engagement, it's not patient
Mm.
partnership. But that ability to look out the window and always make sure that we're talking to new voices and hearing new voices and hearing those voices that we sometimes don't hear, in terms of making sure that services work for them. So I'm mindful of time, and I'm just going to take us on to listening, and something
Mm.
that's really close to my heart, because and in your annual report for 2022 to 23, you talk about you wanting us at the health service to be able to look back in astonishment around how we didn't listen to people, and listen to patients. What needs to change, Henrietta? Because you're talking about it, I'm talking about it, you and me meet lots of people, and I'm sure everyone on this call talks about it. What needs to change? That patients' views are equally valid, that people are listened to, and that, that what they're saying is taken into account and not seen as oh, they're talking again.
Well, I look out to other sectors, I look out to other countries and think about what we can learn. And I was in the Geneva for a week with the WHO, not only in terms of this year's World Patient Safety Day and the theme of listening to patients, engaging patients for patient safety, which was amazing because it was my first time at that meeting, but everyone was saying it was really different because there were patients there were families there, and they were absolutely giving an account of their experience. And I think one of the things that came through really strongly from that is the idea that it shouldn't be a patient story, because if a clinician tells something, it's evidence. And if a patient tells it, it's a story. And we're not there, for entertainment. So I really took a lot from that. And what I would say is that hearing the accounts of the evidence, the experience of patients and families from across the world, it was so consistent. And so I think we can say this is not an England problem. This is it's a global issue. And it's one that seems to pervade healthcare. It doesn't in other sectors, perhaps, but it does in healthcare. And then for the final 2 days that I was there, we spent the time listening to accounts from patients and families and looking at some of the themes that are emerging from that. And that's why I feel really passionate about this, because I do think we can get examples from overseas, really good examples, but also from other sectors as well. And I was reading Terry Leahy's autobiography. He was the chief exec at Tesco. And at Tesco, if you go into a branch of Tesco, they all feel slightly different. Yes, you're going to get some of the same products, but they go out to a panel of people who live nearby or who are going to shop in the store and say, what would you like to buy? So in some areas you might get, you know, more Polish foods, and in others you might get more sort of Asian foods. And it's because that's what the local population want to buy. And I was thinking how incredible and how it seems really straightforward that you're going to want to put products into your shops that people are going to want to buy. Whereas in healthcare, it sometimes feels a little bit more like this is what we're going to provide you with. And so I'm really interested in how, for example, ICSs and others are getting that really meaningful patient engagement, because it's about responding to the needs of communities and then matching that with what we are providing as a healthcare system. There was an interesting report that came out from the medical technology group called Meaningful Patient Engagement. And I'm sure the one maybe Sarah could put the link in the chat because we were at the launch. And what they did was they asked the ICSs about what they're already doing. And I think the word meaningful is a really important word in this, because sometimes people say, look, I was asked for my views, but it was just meaningless, tick box. It was, you know, tokenistic, and it was when all the decisions had already been made. And there's a map in the report which sets out which ICSs are doing a lot of meaningful patient engagement, and others are doing some, and others maybe not so much. And what I would really like to see is that the areas who are doing really well would be happy to sort of share with those who aren't doing so well, because I think everybody wants to get this right, but it's skilled. It requires a lot of skill, it requires resource, and it also requires the right cultures, the right behaviors. And I saw in the Q&A, somebody had put about culture as a real issue, silencing patients. So these are the issues we need to work on. We need to work on the structures that are in place. We need to look at the processes that are in place. And there are some trusts, for example, who respond, they delegate the responding to patients to the front line and using care opinion, whereas others, it all comes through the chief exec's office. And I think that's something we need to be trusting patients to give us the information, trusting the workforce to be able to giving a response. But I think also we need to be thinking, how can we look at other industries? How can we look at other sectors and other countries and learn from their experiences, have that humility to say, we could try this in the NHS and we could actually make it work, and what a difference and what a benefit it will be, not only in terms of the experience of patients, the safety, outcomes, but also in terms of, budgets. We know that that's really important. People talk about finance a lot, but if we get things right and we reduce harm, then we free up time to care, we free up the resources as well. And, that's, I think, good news all around.
Yeah, and that's why we launched our 6 principles of patient safety, because we really believe that it proves that there's quality of outcomes. But actually, if you're partnering and listening to patients properly, it will be a more cost effective service, but it'll also be a safer service. And we all know that, so we need to do that differently. Henrietta, before you joined as patient safety commissioner, of course, you were the Freedom to Speak Up guardian. And what do you think the links? I'm looking quite deeply at the whole link between the psychological safety of staff and therefore listening to patients. And I think that fits into the culture piece as well. And quite often staff are patients, and we've heard from, I'm sure you've heard stories, but I've heard stories from NHS staff who don't feel that when they're a patient or their loved one is that they're being listened to either. So what's the link between the safety of staff and patients, do you think?
Yeah, so there's really important, and the report, two sides of the same coin. I think safety of staff is something that we can't ignore in this, because if your person who's looking after you is not having a good time, whether that's because they are fatigued or they are, really stretched. They might be facing, negative experiences at work. There was a recent report about sexual safety for staff. All these things are going to impact on the ability to provide compassionate care and that listening that you mentioned. So I think that I look at this in terms of the culture that is set in an organization, and the culture comes from the leadership, and we can have leaders at all different levels in an organization, but there's definitely something about the role of boards and the role of senior leaders in setting a culture of listening. I've seen some fantastic examples of that, and I've also, particularly in my previous role, seen examples where it was just the last thing that you'd want as a patient, or as a worker. And I think that when it comes to being genuinely interested in the views of your patients and families and carers and of your workers, that's a really good starting point. And I think that if we could get into a situation where there is that curiosity rather than defensiveness when feedback is given, that's also really important. And the culture doesn't stop with the boards of NHS trusts. The culture is us, it's everyone, it's all these different aspects. It's the behaviors in leaders, in the regulators, in officials, in the manufacturers, in all of these different aspects. And so I see that the culture is something that everybody needs to own. We can't say if they could do it right, we'd all be fine. But at the same time, I'm seeing some real enthusiasm from some senior leaders, particularly in trusts, to learn more about patient safety, to get involved in it. And I'm really keen that there's real opportunities for development as well. So that, for example, the non-exec directors get more information about patient safety. They're able to ask the right questions at board, and also to get support, and networking as well. So these are all different areas that I think are going to make a difference.
Right. And I think you were very clear in your annual report as well, around that we all have a responsibility in this. We have a responsibility, as a patient association, we have a responsibility in how we're working with patients in partnership, but also how we're representing those views when we go into other bodies to represent it. And one of the word that is hitting me at the moment, and you just used it, and I wrote it down 2 seconds before you said it, just to say, was around curiosity.
Mm,
And how do we bring curiosity and humility that you mentioned a few minutes ago into that culture? Because I think they're they're the language that if we look at that more, and kindness, and bringing kindness into it. And one of the pieces of work that we've been involved in recently is around it was called did not attend. And getting, Stella Vig, who is a senior clinician within, I think she's in Croydon, but she talked about curiosity to
mm.
understand why the patients coming to her clinics weren't attending, and working with them to try and understand that. And we talked about that this morning with Bola as well, is that curiosity and kindness. And how do we embed that into the culture within the NHS?
Yeah, well, it's a really huge topic, because I mean, kindness is something which has come into good medical practice, which is the guiding principles for doctors, all doctors in the UK. I was part of the review group of good medical practice, and what an absolute privilege to do that, because it's a generational document, so it should direct the not just the behaviors, but also the culture, I would say, in terms of medicine, because it's about being kind to patients. Now, that's not to say every time someone comes to you and says, "Can I have a prescription for X or Y?" you go, "Yes, here you are, because I'm being kind." It's actually about thinking about the empathy gap that some people experience. It's about kindness to colleagues as well, and the difference it makes if you work in an environment where people are kind compared to unkind, which is obviously that nobody wants. But then there's a question: how do you regulate that? And I think that's a good question. There's also something about when it comes to the behaviors that we see in terms of listening, and is it is it kind not to listen? And I would say no. That's actually unkind. But it's not just about being nice, you know. So I'm part of a group that meets once a month to talk about kindness. It's a global group, and we discuss things like the difference between being nice and being kind, but also, can you regulate social movements? You know, these are all important sort of philosophical topics to get us to a place where we can say, what would we want to see for our loved ones? What would we want if one of our loved ones was, you know, having a treatment, being an inpatient, having an interaction with a healthcare professional, and then building it up from there.
Just realised we obviously talked about kindness last year as well, Henrietta, because you told me about that global movement, and I remember being really intrigued by it because it sounded like a wonderful thing. Uh, Debbie Roberts has just put into the chat box, and we'll take your email address, Debbie, and get in touch with you about she's CEO of the Ollie Foundation, which is a suicide prevention charity, just so we don't lose that in the chat, but we'll definitely get in touch with you. I'm going to look at some of the questions now that so there's definitely a question that is going back to the medication reviews that we talked, the medication leaflets that we talked about. And yes, the legislation is as statutory, as I always get confused, that they need to be printed. But the language in there isn't accessible. You know, it's not plain English even, is it?
Mm.
Do you know, is there any plans, or if someone wanted to look a bit deeper into it, is there a link that we could send out to people?
Yeah, so I think that's a really good question from Justin. The reason I think what's important is that, yes, the language that's on a patient information leaflet is statutory, but for some people it's too little and for some it's too much. And apparently a recent survey showed that only 10% of people read the patient information leaflet. So it's not getting to where it needs to get to. So the question is, if there's some high level information that people need, is that, you know, doable? And then how do you then say, I'd like to know more, I'd like to know more? And I think we've got really good examples of that from other information that's provided. So that's the type of area that the task force that I'm on is looking at, not only in terms of what has to be provided, but also what's additional. And I think that when you look at, for example, the NHS UK website, there's a lot of really useful information on there, which is at a more straightforward level, and people can then, you know, access further information from that. But it's very disjointed. So if we get a medicine, you get a box of medicine, it doesn't direct you to the NHS UK website. It doesn't direct you to other websites that might have more accessible information on. And I think that's the direction of travel, so that somebody who wants to get some high level information can, and if you want to get much more detailed information or an update, or even to know what might interact with your other medicine, that there's a way of accessing that, which is really straightforward and is timely, so you get it when you need it.
Thank you. Now, I cannot multitask in trying to really actively listen to you so I can come back with questions. But I just, Liz Butterfield, I see is here, and she's a pharmacist, and I know that there is a link to a report. I don't know if Liz can get it and put in the chat that people might be interested, which was one of the, I think you were involved in this, Henrietta, as well. It was an AHSN in Kent, if I remember, that looked at digitalisation of patient information.
Yeah,
And
yeah, that's right. That's the report, Reimagining Medicine's Information.
put that in the chat. That might be handy for the gentleman. Why did I decide it was the gentleman that asked that question? I probably saw a name. That's probably why I did. So if somebody else in the chat, Henrietta, is saying it's so helpful to hear from you today, and you're getting there's some lovely messages coming through, which is great. But you know, both of us know Robert Francis really well. We know the mid staff. He was the president. He's president of the Patient Association. Worked closely with you when you were at the Freedom to Speak Up Guardian, I think. But you know, we look at mid staff, to go back 10 years to mid staff and come to today, and yet every report into failings is citing listening as one of the biggest issues. So just, you know, and I'm really mindful of this as we've looked at the last few weeks of what we're hearing as well. that we continually come back to to listening. Yeah, and yet we have documents like the NHS Constitution. We have, you know, what are the barriers, do you think, to listening? I know we've talked about what you want to see, in your vision, but what I'd love to understand more why there are such barriers that we time and time again see these reports where there's been patient safety failings, and yet we hear this word listening. Why is it so complex for us to get this right?
Well, I'm going to go take you back on a history lesson all the way back to the 1990s or even 80s, actually, when I started my training. And we were actively taught not to listen to patients, I would say, because the way we were taught to take a history, which is, when the doctor or nurse asks you the first load of questions about yourself, it was, people are going to tell you a whole load of stuff. And what you want to do is extract out of that the relevant information. That's essentially how I was taught. And that was at London Medical School. And so we learned to disregard a lot of the really sort of nuanced information that we were being given, to kind of reduce it down to the headlines. We were told, think about it like the news at 10. What are the headlines? Abdominal pain. Okay. Upper abdominal pain. Okay. But the fact that somebody had been walking down the pier at Brighton and eating an ice cream, and then an hour later they got their abdominal pain, that's what tells you the diagnosis. And I was very fortunate, as a GP trainee, to go on a course for a year at the Tavistock part-time. And it was about listening to patients, and it was about understanding the patient narrative. And every single word that someone tells you is gold dust, because in the words of William Osler, who died over 100 years ago, listen to your patient because he will tell you the diagnosis. Insert she, or they. Um, and I think what's really sort of so vital about this is that if you listen, your patient will tell you everything you need to know. And if you try and reduce it down to the headlines, you're going to be barking up the wrong tree. And that's often what happens, is people get a fixed idea of what's wrong, and they start making the diagnosis, and they start planning the test and doing all of that based on something that isn't correct, because they've missed the vital information that the patient is trying to tell them. I don't know why people end up in that situation, because actually it's that sort of jumping to conclusions. And why we do that, it's human, it's the way our brains are designed in terms of pattern recognition and, heading down. But if anyone here on this call has read Black Box Thinking, they'll know that this is not restricted to healthcare professionals. This happens in the police. This happens in other industries as well, where people get such a fixed view of things and they get a closed mindset about it. And opening up that mindset means that they might have been wrong. Now, that's where I think we have to have that humility. We have to know that we're not always right. No one's always right. And where do we bring in that other perspectives, that insights, to help then unlock the next steps to go towards getting to a diagnosis, making sure the treatment is really bespoke to that individual. So that's where I think, but I'm sure there are many other reasons why.
Yeah, I think well, what you say stands up quite a lot into one of the surveys that we did a couple of years ago around shared decision making from a healthcare professional's perspective, because we had done surveys in fixed groups of patients and understood the barriers, and then we did one with healthcare professionals. And on the whole, the healthcare professionals who completed the survey were very, very positive, but you definitely could make a link back to time of training. And I know there's some fabulous work going on in terms of training. Uh, Rubina Shah's doing work up in University of Manchester, do double day or I think sure it's double day. Sarah will tell me I got the name wrong, about really getting patients involved as partners through the training, so that patients are there all the time. Because for me, it's like a jigsaw, isn't it? If if you were my GP and we're working together to try and find out what's going on with my health, there is something there's something about that jigsaw that I can tell you lots, but you as a professional can then fill in the other bits for me, and together we complete that jigsaw and I get the right treatment.
Well, I've heard that described as, don't don't mistake your Google search for my 5 years at medical school, and the response is, don't mistake your 5 years at medical school for my 20 years of living this with this condition.
Yeah, I saw that a few weeks ago and I loved it.
And I think there's something about being respectful. It's respectful of when somebody's not sitting in a GP surgery for their 10 minutes, they're living their life with the problems they're having, the symptoms, the signs, and the consequences of any treatment. So it's really vital that there is that partnership working. And I know that there are constraints of time. There's a lot of pressure. There's less time to have those really rich conversations. And I think that means that people feel they're not being listened to, but it also means that the people who are the clinicians feel that they're not having that opportunity to be able to provide care in the way that they would like to. And so I think that does create strain. So it's one of those things, I think, that everybody has to be part of this in terms of the solution, but also think about where are the factors that we can have as support in terms of information that people can take away, in terms of opportunities to feedback. I mean, in general practice, we've got ability to send a text and have a reply function. So you can ask a question to your patient and they can tell you what's their preference. And
Yeah.
that's the sort of way that I think, using technology, having information links, etc. It's about putting the power into the patient's hands and their family's hands so that they can be really part of the team. I say they, I mean, I'm a patient myself. So when I'm a patient, I like to be part of the decision. And when I'm a doctor, I like to have patients be part of that decision. So it's good all round.
And we talk about patient power a lot, but I sometimes have to kind of then say, because I do worry that maybe in certain practices, when you talk about patient power, there's something in our theory of change about how we go about our work, is that the professional, not the patient, the professional has to have the confidence to hand over that power as well. They have to be able to understand that sometimes they may not be the right person, or they may not have the answer, and somebody else might be the person who has the answer. And often by giving patients power, patients will turn around and say, okay, thank you for that, but actually, Dr. Hughes, I want you to make the decision for me about what my next steps are, because it's about both sides respecting each other. So I'm going to ask you a nice question. I'm hoping you can answer it. But somebody is saying they want to ask, what has been the most rewarding aspect of being the patient safety commissioner for England?
Oh, well, I see it as, the sort of speak up, listen up, follow up. If somebody has brought, or patient groups have brought problems to us that we've been able to escalate and then see change happen, that's what I think is the real value of this role. It's also getting that sort of listening ear and seeing people change their views a little bit, maybe. It still feels really early days, and I've been really just so honoured by the ways that patients and patient groups have welcomed me into this role, and we've worked together really productively, I think. But it's also really sad when it comes to the challenge. I saw that question, and the challenging side of it is that, when we think, oh, that's great, we've moved something forward, like for example the original packaging, and the patient groups tell me we've been working on this for 10 years, and that is really, demoralizing, because you think, wow, all of that time, to get things to move, and why is the system so slow and disjointed and siloed, all the things that Baroness Cumberledge found in her review. So I suppose from my point of view, the rewarding thing is if we manage to get something over the line, or listen to people and turn it into something that is of value. The challenging bit is, why do we have great innovations happening in some parts of the health system, but they don't get picked up and implemented quickly? And why is it that we're still hearing of examples where people are just having really poor care or really tragic outcomes as a consequence of not being heard?
Like completely. And there's a couple of questions in the chat. I was going to ask you the second part of that person's question, but I thought I'd let you do the positive one first of all. So I'm glad you addressed the challenging one as well. But there's a few questions in there, and there's kind of a theme that comes is that sometimes the system can seem quite defensive in how it deals with listening to patients. And what would your advice? Because I think we all know the system can be defensive at times, and that people feel that they're blocked in taking their concerns further. Do you have any advice that you would give patients in that instance if they feel their voice has been blocked? Because of course your role is only around medical devices, and I know that you've been brought in to deal with some other issues at the moment as well.
Yeah, so I think there are things that I've seen at different points when it comes to people's voices being included, and the more that we can get the views and experiences of patients and families and carers in at the beginning, the better it's going to be all the way through. But I've also seen that the system of complaints, particularly in secondary care, tends to be very kind of antagonistic. It becomes quite antagonistic quite quickly. It separates people from the patients and the families from the people who've been looking after them, and you only see it all coming back together again either through the ombudsman's office who do mediation or through the NHS resolution who do litigation. And people often say that families turn to litigation to get that advocacy that they're looking for in terms of their voice. So I'm really keen that we look at the complaints process and we look at how we can get a much more restorative approach to to the way that when things aren't right, because people on the call might not be aware or might be aware that if there's an incident which is declared by an organization, there's a national approach, there's a national learning that comes from it, but there's no national system of learning from complaints. And it seems to me that diminishes the value of the voice of patients and families, that you have to go through a system which it relies on people having to put all the information in themselves. That might create more barriers to groups that we talked about earlier in terms of left behind communities. But also it means that we're not getting that maximum learning. You might get something that's raised in a complaint in one organization and it could happen 3 miles down the road in another. And that's a real missed opportunity. And it could cause harm, unnecessary and avoidable harm. So that's the approach that I would like to see, is a much more collaborative approach, a partnership approach, learning from the experience. I mean, I'm really pleased that in the new incident response framework, there is a way for families and patients to be involved in a really meaningful way, not just some kind of what did you think of that report way, which was the old fashioned way of doing it, but recognizing that patients and families are seeing everything and they're seeing it in all different parts of the pathway, and that the insights can be as valuable as those from the staff. So there is a good direction of travel, but I think there's still a lot more that could be done.
Yeah, I know when they were looking at Healthcare Act for ICSs, we 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 asked that they did bring in that national system of reviewing complaints. But we asked it for within ICSs, and what we were saying was this isn't about, complaint X and outcomes. It's about themes from complaints.
Yeah.
And we didn't see that would bring a huge amount of work because they've got the information. And I think if you go back to your comment about well, I don't know if it's the word innovation, but what I heard was, we don't move fast with innovation within the NHS or within the health and care system. And but we don't learn fast with learnings because we're not sitting looking at themes across the country and saying, so why is this an issue? And here's an, this is working here, so why don't we bring this over here? And
Yeah.
getting thought-provoking conversations going around, the honesty. And it's not a lack of honesty, but we need to have honest conversations about when things go wrong, why they've gone wrong, and what can be done differently. And I think that has to come from leadership both at a national level and at a local level,
Yeah.
so that we get that right.
Yeah, and I sort of wonder, how an organization gets itself into a place where, reputation of the organization sits on the risk register. Because I always take the view that you develop your reputation by doing the right thing. That's what builds your reputation, not by trying to kind of like ignore or hide things that aren't great. It's about having that, like maybe it is what you were saying before about having that that confidence to recognize that there are things that aren't great and not be worried that the organizations above you or below you are going to be, finger pointing as a consequence. So I do think there is something about the environment that healthcare providers are working in, and having that sort of broader, honest conversation to say where are the issues. And what I've seen is in the organisations where the board really takes ownership of the space and they're committed to listening to their patients and families and to their workers, they can uncover and identify the problems at an early stage and work to fix them, with the benefit of the involvement of patients and families and their workforce, because there's a lot of creativity, there's a lot of knowledge and desire for people to be part of that solution. And we've seen that with patient safety partners, a really great new addition to the governance and the design in terms of the way that healthcare is provided.
Henrietta, we could be here for another hour, but we're coming very close, very fast. And you're getting, you're everyone's thanking you for your honesty, and I know that I can see that every time. Your passion for listening to patients. So thank you from the Patient Association as well. We want to have you back again next year. Hopefully, we'll both still be here. But so if you were coming back in a year, what's your vision for your next year as Patient Safety Commissioner? What do you hope to achieve? And you probably have about a minute to answer that question.
A minute. Well, my team have been reflecting on this and we are looking to refresh our strategy. One of the things that I haven't been able to do this year, because we just haven't got the size of the team to do it, I'll be honest, is the principles on better patient safety. And that's one of the statutory requirements. So I would looking to go out to consultation on that. I'm also, we're really keen that people's experiences form and shape our strategy. So when we go out to consultation, we'll be asking, for views on that as well, because I think we can sit in an office in central London and have an idea, but it's got to be right for everyone. It's got to be right for all patients and people who aren't patients yet. So I'm talking about the public, which I think doesn't often get a kind of look in when it comes to these things. So I think that's what I'm looking for, as a much broader conversation with a really wide group of people to help us to get the right priorities so that we can then move the needle in terms of patient partnership, in terms of listening, that really meaningful engagement that I think everyone would like to see.
Fantastic. Well, Henrietta, you know that we're here to give you as much support because we're completely committed to the role that you do, and to all of your team. So anything we can do to make sure that we can help you with engaging in patients and getting those principles there, we will do that. So we promptly come to 3:30. Thank you all so much. We will gather up all the chats and all the questions. And thank you so much for giving us an hour of your time. And Henrietta, thank you so much.
Well, thank you so much, Rachel. And you say you'll be do anything to support us. You actually do. The fact that we were able to publish a 100-day report on your website because we didn't have a website at that point, that's tangible help. That's more than an offer. So I just want to say a massive thank you to everyone in your team who've been absolutely brilliant.
Brilliant. What a lovely Monday. Unfortunately, we had to talk about safety and stuff rightly, but it's been great to have these honest conversations, and that's what it always feels like when we're talking to you, Henrietta. It's completely honest, and that humility and that kindness comes out hugely. And thank you all for attending. We'll leave it there.